and welcome to OTPs, Choosing the Right Level of Care for Opioid Use Disorder. I am Dr. Eric Morse, and I'm an addiction psychiatrist, and I am recording this in April. May the 4th be with me because I'm not technologically advanced. But I will be live chatting throughout this talk. So feel free to get in the chat box, ask me questions, and I will do my best to answer them as you watch this talk. I am an addiction psychiatrist. I had to leave the state of North Carolina to do training. And I went to the University of Maryland, and from 2002 to 2003, I did an addiction fellowship there. And at that time, I was trained in both OTP, commonly known as methadone clinics. I was also trained in OBOT, office-based opioid treatment. And I've been doing both at the same time ever since. So every day for the past almost 20 years, I have treated opioid use disorder from both an OBOT setting and from an OTP setting. And some OBOT providers may be anti-OTP, some OTP providers may be anti-OBOT. I am pro both. I am a big believer that there's no wrong door. Get into treatment. Once you're in treatment, if you need a different level of care, that's a lot easier than trying to convince someone to get into care. As I guess a matter of disclosure, I've probably in the past 20 years have made about the same amount of money in both. So I don't have, one huge preference over the other in terms of financial reasons. I'm also pro 12-step, do a lot of 12-step facilitation, big believer in NA, big believer in Celebrate Recovery, big believer in Smart Recovery, level 1 counseling, SAIOP. I've worked in SAIOPs, I've worked in detox centers, I've worked in rehabs. And so I have experience working in all levels of care, and they all have their place. But my take-home message, however, is that, in whatever treatment option you're in, whatever level of care you're in to treat opioid use disorder, medication-assisted treatment should be part of your treatment plan, should be an option for you. You should not be denied naltrexone, methadone, or buprenorphine. With the medical evidence so obvious that it is effective, to not at least allow for it in a treatment program, to me, borders on malpractice, is a form of discrimination and probably should be defunded. And that may be controversial. I'm going to get on my soapbox today, and I probably am not going to come off of it. So enjoy this. Okay, advancing my own slides. Here we go. Medication-assisted treatment. So OBOT versus OTP, we're going to talk about that. Medication-assisted treatment is selecting the appropriate medication with a medical provider led by a physician, in my opinion. There should be a counseling component associated with it. You should have 24-hour coverage, so you shouldn't not be able to get in touch with your doctor if you need your doctor. There should be some sort of crisis line for an OBOT or for an OTP. That's expected. It should be maintenance and not detox. The medical evidence for detox is so poor. So if you're going to a program that only does detox, you're probably in a program that doesn't follow evidence-based medicine. And you should have continuity of care after discharge. So opioid use disorder is a chronic medical illness. It is not something that can be treated episodically. We don't treat diabetes just for a couple of weeks. So there needs to be ongoing care for somebody who has opioid use disorder. I'm going to move my little box here. Sorry about that. So what are some of the medication options? Number one, there's methadone. You know, that got its start in the 1950s. The SAMHSA has come out and said, we do not need to continue to study methadone. It's been studied enough. Let's stop. We're not going to fund studies of methadone anymore. It is still considered one of the gold standards in treating opioid use disorder. But in OTPs, we also offer buprenorphine and naltrexone. Buprenorphine, so there's generics, there's, you know, the trade name that most people call it is Suboxone. That's gone off patent. There's Zubsolv, there's Bunavail, and there's the injectable Sublocade, which lasts for 4 weeks. So every 4 weeks you get another shot. There is the buprenorphine implant called Probufene, which is basically the Norplant that has buprenorphine in it that requires a surgery a minor surgery in your arm and has to be removed in 6 months, and another one can be put in the other arm. And then there's naltrexone. So the pill form used to be called Revia, is effective and FDA approved to treat opioid use disorder. And so is the 4-week shot that's given in the buttocks, Vivitrol. There's also a naltrexone implant from My Life Recovery Centers that has a beaded technology that you put in your love handle and dissolves and lasts for about 6 months as well. So those are the medication options. Now, what is OBOT? We think of it as an office-based buprenorphine, but of course, OBOTs can offer naltrexone as well. It's not legal for someone to prescribe methadone out of an office for the purposes of opioid use disorder, excluding the 72-hour rule. So the Data 2000 Act created an X waiver system. So you'll hear people saying, do you have your X waiver and are you using your X waiver? And that's what that is referring to. Buprenorphine can be prescribed out of any medical practice, just like you would get any other prescription from any other doctor to treat any other chronic medical illness. And so the point of the Data 2000 Act, in my opinion, was that we would all get waivered. You know, every doctor would go ahead, do the 8-hour training, and then provide buprenorphine out of your office, just like treating any other illness. There wasn't supposed to be, and I don't think they were anticipating there'd be Suboxone clinics, right? Where you go to an office and all you get is Suboxone. The whole point of this was that it was going to be mainstream, that the stigma would be reduced, that you wouldn't know, while you're sitting in a waiting room, you'd be treated like any other patient. The whole point was to reduce stigma. And we thought every primary care doctor would do it. Every psychiatrist would do it. That hasn't happened, unfortunately. And most OBOTs now need to be offering Narcan to their patients as well. What should an OBOT not be? I don't think it should be a Suboxone clinic. I don't think that's the only thing you get when you go there. That really wasn't the spirit of the Data 2000 Act, in my opinion. And it should be mainstream. It should be destigmatized. OBOT should also not be in the hands of non-medically trained people. So there shouldn't be a non-prescriber handing out medicine in an OBOT. So PAs and NPs can now do a 24-hour training and get X waivered, and that hopefully increases access to care for folks who suffer with opioid use disorder. I think that's absolutely appropriate and fantastic improvement. I don't think that OBOT should be marketed with road signs with microloans. I don't think it should be web-based only. I think that there's, when people are talking about, the market space or a cash cow, when you hear physicians charging more for a Suboxone appointment than one of their regular appointments, I think that's a form of discrimination that should not be. And I don't know what to do about that. Methadone from an opioid treatment program. It's been around since the 50s. It is probably the highest regulated form of treatment of any other, medical illness. So the OTPs, we are inspected and regulated by the DEA, DHSR, the North Carolina State Opioid Treatment Authority, NC Drug Control, our managed care organizations, SAMHSA and CSAT, and CARF, or JACO. It's been around, it's been federally approved since the 70s, and ironically, it got approved when studies showed that it was much more cost effective than putting folks who suffer with opioid use disorder in jail and prisons. And it's kind of coming full circle in a way, and we'll get to that in a little bit. Counseling is mandated, both individual and group counseling. There's a 50-to-1 ratio of patients to counselors that's mandated. In an OTP, there is a higher level of structure. Patient doses, whether they're getting methadone or buprenorphine, they're going to dose daily, usually for the first 90 days. You can put exception requests in, particularly now with COVID, but also with buprenorphine, you can earn take homes faster. Methadone is a long acting opioid analog. So the whole point is that you take your methadone once a day in front of a nurse. And you know that for at least the next 24 hours, you're not going to be going into withdrawal. You're not going to have significant cravings. And if you were to use on top of it, you would be blocked so that you would not be able to get the euphorogenic effects of using the opioid of your choice. Cost is fully covered by Medicaid and Medicare, so our patients do not have any copays. And then we also have the SOARS grant, or the SOARS grant 2, where folks who do not have health insurance can also get free care. And then every patient in an OTP gets a Narcan rescue kit. And there's no question that we save a lot of lives. So let's go to the mu receptor. Okay, so that is the receptor that opioids work on to cause euphoria and further downstream usually oftentimes causes addiction. And so comparing the 3 medications approved by the FDA for opioid use disorder, you have methadone, which is a full agonist, so it has 100% activity on the receptor. There's buprenorphine, which is a sublingual medicine that you take, and it's a partial agonist. Also, it's an antagonist. It has about 30% activity on the receptor. It is a beautiful molecule in that it's just enough to cover withdrawal, but not enough to get you high if you're opioid naive. If you're opioid naive, you can get euphorogenic effects, about 30% euphorogenic effects. But for someone who is opioid dependent, they would not be able to get the euphorogenic effects. And then naltrexone, which is just an antagonist. So it sits on that receptor. It has no downstream effect. It does not cover withdrawal, but it does reduce cravings. And that's how it is effective. It also blocks euphorogenic effects of other opioids. And, comparing the two, buprenorphine tends to be a safer medicine because it has a ceiling effect. So you can take more and more buprenorphine and it's by itself, it's difficult to overdose with. There have been some cases and people are investigating that, but for the most part, it's a safer medicine than methadone. It's sublingual, so it bypasses the liver. So there are fewer drug-drug interactions with buprenorphine than methadone. It's also a lot easier and faster to get to a therapeutic dose. So typically we start people on 8 milligrams on day 1, 12 milligrams on day 2, and 16 milligrams on day 3. And by day 3, you're at a therapeutic dose. That is not the case with methadone, where a safe induction, usually it takes weeks to months to get to a therapeutic dose. And I think buprenorphine is more readily available on the street and can be prescribed by any medical provider. It always helps to have the X waiver, but you can prescribe it off label without an X number. Methadone, you can only get for the purposes of opioid use disorder from an opioid treatment program. Its half-life is more variable than buprenorphine because it's metabolized in the liver, and depending on how healthy a liver you have, and there's some genetic variants as well, methadone can accumulate and has greater overdose potential. And that's why it's given in a very structured way, very safely in our opioid treatment programs. So it does take longer to get to a therapeutic dose. It is more effective for pain because it has 100% activity on the mu receptor and probably on the sigma and kappa as well. It does tend, a lot of our patients got on opiates because they had legitimate pain. And so, some people ask me, well, do you see buprenorphine just wiping out OTPs? No, there's going to be a subset of folks who are going to get benefit from methadone for pain that's greater than the benefit for pain from buprenorphine. The other piece of this is that it may be better for folks who are in the contemplation stage of change. So for someone who's not sure they want to get completely clean and sober, methadone allows you to still get some euphorogenic effects, while buprenorphine, because it has such a high binding affinity, because the receptors are saturated pretty much at 16 milligrams, you don't really have the option of getting the euphorogenic effects of opioids unless you plan to get off the medicine in advance. So there's benefits and drawbacks to that, based on the patient's view. Let's talk a little bit about the hub and spoke model. I've heard some folks talk about the hub and spoke model from like university center OBOTs to community OBOTs. But when I think of the hub and spoke model, that was developed in Vermont, it's the OTPs are the hub, and the local OBOTs are where people kind of graduate from. So the OTPs, a higher level of care, oftentimes what we'll do with our buprenorphine patients, the patients who come in choosing buprenorphine, is we'll get them clean, sober, and stable. And then once they're, they have their life where they want to be and they want more freedom, and maybe find somebody who's closer to them, and maybe somebody who takes their private insurance. They then find an OBOT provider in the community, and they're a much more attractive patient to that OBOT provider when they're already on buprenorphine. So they're already clean and sober. You can get records from the OTP. I mean, that is, they don't have to be induced, and that's an easy patient to accept. Those are the folks that I like to see from my OBOT at Carolina Performance. Those are patients that are much easier to engage with. So, and for my OBOT providers from the 8 OTPs that I have, I reach out to the OBOT providers and say, send us the ones who are struggling. The folks who are still testing positive, who need that extra structure, that extra supervision. If you're concerned they may be diverting some of your buprenorphine, they can't do that with us because we watch them dose. So, send them to us. We will get them clean and sober, and then we will send them back to you when they've stabilized. So the hub and spoke model really provides OBOT providers a safety net. They know that if they get into trouble with a patient where they're not sure what to do, they can refer them to the OTP. We can get them back to where they need to be, and then back to their OBOT provider again. And I'd like to point out that it's not just the medicine and the supervision and the structure. I mean, those things are extremely important, but it's also the coordinated counseling in an OTP that really makes a difference. The fact that we are a team in an OTP, the nurses, the doctors, the counselors, the front desk staff, the security folks, we all put our heads together. We have treatment teams. We discuss some of our folks every week, and we're trying to help people. And that higher level of care can be very helpful for a lot of our patients. And I will say that, I'm a big fan of the STOP Act. I think we're seeing a lot less iatrogenic addictions, people who are started on opioids and continued on opioids by physicians. I think it's a great thing, but I think one of the maybe not so expected consequences is that it's the law of supply and demand. As there are fewer legitimate pills on the black market, people are really turning to carfentanil derivatives. And that has really changed, the lethality of using, obviously, because carfentanil derivatives are so much more potent that one use really can lead to death. And it's very hard to predict. And a lot of the carfentanil now are being pressed into pills that are made to just, look just like, stamped with the same number and everything. They're stamped to look like an oxycodone. They're stamped to look like a Vicodin or an OxyContin. And so what you think you're taking and what you're actually taking can be two very different things. And so big believer in it, big believer in the STOP Act, but I think one of the unfortunate consequences and is the rise of carfentanil derivatives. And from an OTP and an OBOT standpoint, it has changed my view, and I think most providers' view of making sure people get on methadone, buprenorphine, or naltrexone. It used to be someone could use, they're not ready yet. They could use and come back when they're ready. And no one says that anymore. You have to be ready now because the next time you use could be the last thing you do. And so we're big believers in getting people into treatment and keeping them in treatment, engaging them, keeping them in treatment, even if they're continuing to use, if they're using less, you know, in a harm reduction kind of model, that's still better. You know, how many bullets are in the gun when you're playing Russian roulette? If there's only one, you have a much better chance of survival. So if you're only using once a week, that's better than the alternative if we kick you out and you go back to using 3, 4, 5 times a day. So it really has changed, I think, the demand to get people into treatment more quickly. And, you know, this is a reflection of that. I mean, why are we seeing so many more opioid epidemics despite, you know, more of an emphasis on this, despite more spending, you know, despite more Narcan? And it's because of the rise of carfentanil derivatives. And, you know, yeah, I've been at it 20 years. People were dying 20 years ago, but not at the rate that they're dying at now. And let's be honest, you know, some of the people who are dying now, they're wealthy white people. You know, back 20 years ago, it was mostly minorities. And so it's more of a political issue because it is affecting people who have the funds to do something about it. And so there's definitely some racial disparities, and that's off topic, but it's on topic too. So this might be my most important slide. And it's part of it is comparing apples to oranges a bit. And like I said early on, I am pro-treatment in whatever form of treatment people are willing to do. But when you look at outcome measures, you'll find, and you know, in this comparison, you're looking at opioid free after 6 months of going into treatment. So, you know, there are a lot of people who drop out of treatment. So NA, and this has been studied many times, NA has about a success rate of about 8%. Now, it works if you work it. There's no question. And I'm not poo-pooing NA. But, you know, you have different levels of engagement in NA. Some people go because, you know, they're being forced to, or they don't really want to. You know, there's family pressure, what have you. As opposed to somebody who goes to an OTP, they're usually pretty ready to stop using. So I know that there's biases in looking at the data, but for the most part, NA has about an 8% success rate when you're talking about 6 months later, are you opioid free? And that's a lot of, for NA, a lot of that is telephonic data, which is usually overreported. And so that percentage may actually be lower. Most inpatient detox rehabs that do not have medication-assisted treatment have success rates around 10 to 15%. And that's 28-day programs, that's 5-day programs, kind of lumped in there. But if there's not medication-assisted treatment, and looking at a JAMA article from 2020, only 2% of rehabs in the United States allow for methadone, and only 33% allowed for buprenorphine, and only 29% allowed for naltrexone. So the rates of that are really poor. There's a lot of stigma even within my own profession against obvious medical evidence. Methadone success rates are 60 to 80%, buprenorphine 70, 80%, the buprenorphine implant was 80%, oral naltrexone, particularly in patient populations like airline pilots and physicians, 40 to 50%, the naltrexone Vivitrol, implant, the injection is 60 to 8%, and the naltrexone implant, their study showed there was about 80% success rate. So this is why in any other form of medicine, if an emergency room physician or a primary care physician or a psychiatrist recommended treatment that had an 8 to 15% success rate, as opposed to something that had a 60 to 80% success rate, in any other field of medicine, that would be considered malpractice. In the addiction world, it isn't. I think it's because of the stigma, how our patients are marginalized. No one's sued over it yet. But in any other field of medicine, this would be appalling that you would be able to go to a place for help and not get where the medical evidence is, not be able to get medication-assisted treatment. And so, again, I said at the beginning, I say it again right now, if there are programs, if there are hospitals, if there are jails, if there are prisons, if there are rehabs, detox centers that do not allow for medication-assisted treatment, I believe that borders on malpractice. I think that's, discriminatory. I don't know how that could be considered legal. We don't have, rehabs that don't allow for insulin. Why wouldn't we allow for methadone, buprenorphine, or naltrexone? I think it's because of ignorance and not following medical evidence. A lot of addiction treatment, historically has been folks who've been in recovery. And that's great. But, having it medicalized, having a physician for each program is a relatively new phenomenon. And the physicians working in these programs need to get with the medical evidence. And I've already said this. I did list, I've been working on trying with recovery courts and Black Mountain and Dark Cherry to allow for medication-assisted treatment. That's been a pet project of mine lately. Again, got on my soapbox, staying on my soapbox. Sorry about that. And I do applaud Mandy Cohen on her first day after she got confirmed by the Senate. She had an opioid summit conference. And I asked her, would you please have our ADATCs get their OTP licenses back? And she did in very quick form. And so our buprenorphine patients, our methadone patients, our naltrexone patients do have a place to go in the state system, but that should be across the board. That should be every hospital, every rehab, every emergency room, every jail, every prison. And we're beginning to see some lawsuits. I think for too long we've been in the dark. I think it takes a tremendous amount of courage for somebody in recovery to come out and say, hey, I wasn't done right. And I want to make sure this doesn't happen to anybody else. And I think that takes a lot of courage. Trying to find those folks is a huge challenge. And I applaud the folks who very recently have sued and won. And here's another case. So hopefully I've been answering questions in the chat room as you've been watching this recorded lecture. I've gotten to the prepared part of what I wanted to say, but I think a lot of the question and answers are going to be even more valuable. This is the third opioid summit. The opioid summit for me I've been to the first two, and they have been fantastic and inspiring. And And hopefully this talk has lit a fire under someone. Thank you so much. And let's do the live chat, the live Q&A period now. Thank you.